The ICD-10-CM Guidelines for coding and reporting for fiscal year 2022 were updated in April. Not only were chapter-specific coding guidance updated, general coding guidelines were updated as well. In this video, we will talk about those general coding guidelines. And stay until the end, and I'll give you a bonus update in one of my favorite areas. First, let's give some background on the official ICD-10-CM guidelines. The following guidelines for coding and reporting using the International Classification of Diseases 10th Revision Clinical Modification, or ICD-10-CM, are provided by the Centers for Medicare and Medicaid Services, or CMS, and the National Center for Health Statistics, NCHS. Two departments within the United States Department of Health and Human Services, or DHHS. These guidelines should be used in conjunction with the official ICD-10-CM version available on the NCHS website. The ICD-10-CM is a morbidity classification system used in all healthcare settings to categorize diagnoses and reasons for visits. The ICD-10-CM is based on the ICD-10, the World Health Organization's statistical classification of disease. These guidelines have been approved by the 4 organizations that make up the cooperating parties for ICD-10-CM: the American Hospital Association, the American Health Information Management Association, or AHIMA, CMS, and the National Center for Health Statistics, or NCHS. Well, what are these guidelines all about? Before I answer that question, for the newbies in the room, and maybe not so new, let me say, hey there and welcome. If you are new here, you don't know me yet. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And on this channel, I provide you with information, tips, and strategies on how to become a certified marketable medical coder. As a result of my straightforward strategies, tips, and optimistic approach to education and learning, I've served hundreds of students and helped them transform to become certified medical coders who have developed dynamic careers in the business of healthcare and are valuable resources in their own right. Consider subscribing to my channel to get the latest and greatest information and tips you need to become a certified marketable medical coder. And don't forget to hit the bell for notifications of my weekly videos. The guidelines are a set of rules that were created to go along with and complement the official conventions and instructions included in the ICD-10-CM. The classifications, instructions, and conventions take precedence over the guidelines. These guidelines are based on the coding and sequencing instructions in ICD-10-CM's tabular list and alphabetic index, although they go further. The Health Insurance Portability and Accountability Act, or HIPAA, requires that certain rules be followed when allocating ICD-10-CM diagnostic codes. Under HIPAA, all healthcare settings must use the diagnostic codes. To accomplish thorough and accurate documentation, code assignment, and reporting of diagnoses and procedures, a collaborative effort between the healthcare provider and the coder is required. These recommendations were created to aid both the healthcare professional and the coder in determining which diagnoses should be reported. It is impossible to overstate the value of consistent, thorough documentation in the medical record. Accurate coding is impossible without such documentation. To discover the particular reason for the encounter and the conditions treated, the whole record should be reviewed. The term encounter is used for all settings, including hospital admissions. In the context of these guidelines, the term provider is used throughout the guidelines to mean physician or any qualified healthcare practitioner who is legally accountable for establishing the patient's diagnosis. Only this set of guidelines, approved by the cooperating parties, is official. The guidelines are organized into sections. Section 1 includes the structure and conventions of the classification and general guidelines that apply to the entire classification, and chapter-specific guidelines that correspond to the chapters as they are arranged in the classification. Section 2 includes guidelines for selection of principal diagnosis for non-outpatient settings. And then Section 3 includes guidelines for reporting additional diagnoses in non-outpatient settings. Section 4 is for outpatient coding and reporting. It is necessary to review all sections of the guidelines to fully understand all of the rules and instructions needed to code properly. So let's dive into these new updates. Section 1B starts the general coding guidelines. Section 1B2, level of detail in coding diagnoses codes, are to be used and reported at their highest number of characters available and to the highest level of specificity documented in the medical record. Next, Section 1B13, laterality. When laterality is not documented by the patient's provider, code assignment for the affected side may be based on medical record documentation from other clinicians. If there is conflicting medical record documentation regarding the affected side, the patient's attending provider should be queried for clarification. Codes for unspecified side should rarely be used, such as when the documentation in the record is insufficient to determine the affected side and it is not possible to obtain clarification. Section 1B14, documentation by clinicians other than the patient's provider. Code assignment is based on the documentation by the patient's provider. For example, the physician or other qualified healthcare practitioner legally accountable for establishing the patient's diagnosis. There are a few exceptions when code assignment may be based on medical record documentation from clinicians who are not the patient's provider. In this context, clinicians other than the patient's provider refer to healthcare professionals permitted based on regulatory or accreditation requirements or internal hospital policies to document in a patient's official medical record. These exceptions include codes for body mass index or BMI, depth of non-pressure chronic ulcers, pressure ulcer stage, coma scale, the NIH stroke scale, social determinants of health, laterality, and blood alcohol level. This information is typically or may be documented by other clinicians involved in the care of the patient. For example, a dietitian often documents the BMI, a nurse often documents the pressure ulcer stages, and an emergency medical technician often documents the coma scale. However, the associated diagnoses such as overweight, obesity, acute stroke, pressure ulcer, or a condition classifiable to category F10, alcohol-related disorders, must be documented by the patient's provider. If there is conflicting medical record documentation, either from the same clinician or different clinicians, the patient's attending provider should be queried for clarification. The BMI, coma scale, NIHSS, blood alcohol level codes, and codes for social determinants of health should only be reported as secondary diagnoses. See Section 1C21C17 for additional information regarding coding social determinants of health. Next is Section 1B18. use of sign, symptom, and unspecified codes. Sign, symptom, and unspecified codes have acceptable, even necessary uses. While specific diagnosis codes should be reported when they are supported by the available medical record documentation and clinical knowledge of the patient's health condition, there are instances when signs, symptoms, or unspecified codes are the best choices for accurately reflecting the healthcare encounter. Each healthcare encounter should be coded to the level of certainty known for that encounter. As stated in the introductory section of the official coding guidelines, a joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. The importance of consistent, complete documentation in the medical record, again, cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. The entire record should be reviewed to determine the specific reason for the encounter and the conditions treated. Section 1B19D, use of Z-codes. Z-codes, other reason for healthcare encounters, may be assigned as appropriate to further explain the reason for presenting for healthcare services, including transfers between healthcare facilities or provide additional information relevant to a patient encounter. So you have learned that with the new ICD-10-CM code updates in April, the official guidelines were also updated. You've also learned some background and purpose of those official guidelines. And lastly, you have learned what general coding guidelines were updated. Questions of the day. Did you know about this? What do you think about these updates? And are they helpful? Let me know in the comments below. I would love to hear your thoughts. My final thoughts. While there were notifications about the ICD-10-CM codes being updated twice a year, and with that, the possibility of the official guidelines being updated, there hasn't been a lot of discussion about these updates, especially when they involve general coding guidance. To me, that is huge. Well, you know, I'm going to keep you in the loop, so stick and stay, and you will be in the know. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key, providing you with information, tips, and strategies on how to become a certified marketable medical coder. And if you are interested in more information on these tips, guidelines, guidance, and others on how to become a certified marketable medical coder, well then check out these videos and check this out. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. If you liked the video, don't forget to let me know by hitting the thumbs up, hitting the subscribe button, and the notification bell so you are informed every week when I upload new content. I love hearing from you, so let me know you were here by providing a comment or asking a question. You can also give me a little love by sharing this video on your social media platforms. Tag me in your video share at PRNcoding.edu. Let's stay connected and connect others. Well, you have stayed until the end. Let me know in the comments where you are checking in from. And here is the bonus information I promised. If you have followed me, you may have guessed one of my favorite areas of coding and compliance. If you guessed behavioral health, you are correct. Well, let me spill a little tea here. Section 1C are the chapter-specific coding guidelines. And as I mentioned earlier, in addition to general coding guidelines, these are guidelines for specific diagnoses and/or conditions in the classification. Now, unless otherwise indicated, these guidelines apply to all health settings. These updates are for Section 1C5, Chapter 5, which is the Mental, Behavioral, and Neurodevelopmental Disorders, F01 through F99. And B, Mental and Behavioral Disorders due to psychoactive substance use. So guidelines Section 1C5B4, Medical Conditions due to psychoactive substance use, abuse, and dependence. Medical conditions due to substance use, abuse, and dependence are not classified as substance-induced disorders. Assign the diagnosis code for the medical condition as directed by the alphabetical index along with the appropriate psychoactive substance use, abuse, or dependence code. For example, for alcoholic pancreatitis due to alcohol dependence, you assign the appropriate code from category K85.2, alcohol-induced acute pancreatitis, and then the appropriate code from subcategory F10.2, such as code F10.20, alcohol dependence uncomplicated. It would not be appropriate to assign code F10.288, alcohol dependence with other alcohol-induced disorder. Also, an extra bonus guideline because I'm feeling generous today. Section 1C5B, 5, alcohol level. A code from category Y90, evidence of alcohol involvement determined by alcohol level, may be assigned when this information is documented and the patient's provider has documented a condition classifiable to category F10, alcohol-related disorders. The blood alcohol level does not need to be documented by the patient's provider in order for it to be coded. If you want to learn more about the wonderful world of health information, medical coding, and/or compliance, then watch one of these videos. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care, and thanks so much for watching.